Hello, welcome to our cardiac MR stress imaging clinical workshop here at the London Chest Hospital. I'm now going to talk to you about indications and contraindications and risks of cardiac MR stress tests, and I'll touch on the nephrogenic systemic fibrosis issue. Learning objectives of this talk are that at the conclusion of this presentation, you should be better able to list the most common clinical indications for cardiac MR stress tests, contrast the role of cardiac MR stress tests with other imaging modalities, recognize important contraindications to cardiac MR stress tests, and review the safety of MRI contrast agents and the relative risks of allergic reactions and NSF. In this report, in 2004, you'll find the clinical indications for cardiovascular magnetic resonance as a consensus panel report. And this table 3 looks at the indications for cardiac MR in coronary artery disease. And I've underlined here the two indications that we will talk about in this lecture. And in fact, the regional left ventricular function at rest and during debutant stress can help detect coronary artery disease, or alternatively, the assessment of myocardial perfusion. Both got a class 2 indication, so they're perfectly sound tests, but there are other tests that can also give you that information, and we'll come back to that in a little while. So the new NICE guidance, which were published fairly recently in the UK, try to make it very simple, try to simplify the approach to patients with stable coronary artery, chest pain. And depending on the pretest probability, which depends on the age, the gender, the presence of risk factors, and the typicality of chest pain, you can be categorized into either low likelihood of coronary artery disease, 10 to 29%, intermediate likelihood 30 to 60%, or high likelihood 61 to 90% pretest probability of having significant coronary artery disease. In the very low risk population, the guidance suggests to do a coronary CT calcium score. Now, if this comes up with any suggestion that there may be coronary artery disease, then a non-invasive functional imaging test should be offered. And now we're talking about cardiac MR imaging with either first pass contrast magnetic resonance perfusion, or alternatively MR imaging for stress-induced wall motion abnormalities. As we're talking about these non-invasive functional imaging tests now, clearly you can also offer an MPS with SPECT or stress echocardiography, and which one you go for often depends on your local environment, which test is more available. Here at the London Chest Hospital, we perform MR perfusion scans in most patients in this category. Now, if you're intermediate likelihood of coronary artery disease, then you should offer a non-invasive functional imaging test straight away. So no coronary calcium score, but one of these tests straight away. So in our setting, this is frequently MR perfusion scans. If you've got a higher likelihood of coronary artery disease, then you should really offer invasive coronary angiography immediately. Now, for some reason, this may not be the first choice because the patient may not want it, or there are other reasons. In this case, it is okay to offer non-invasive functional imaging tests. And again, in our situation, this is often MR perfusion scans. Now, even if you offer an invasive coronary angiography, you may still find some ambiguity whether there's significant coronary artery disease, whether an artery is actually significantly narrowed to warrant treatment. So in those cases, you can then offer non-invasive functional imaging to see whether the stenosis is actually significant and causes either a perfusion defect under stress or a wall motion abnormality under stress. And again, MRI is just one of the choices you could offer. So more specifically, the indications for cardiac MR stress perfusion or debutant CMR is to mention in suspected coronary artery disease. So this is according to the NICE guidance for the detection of ischemia, and as you've seen, it can be either the primary investigation in those intermediate risks, or in the high risks if invasive coronary angiography for some reason can't be the first line investigation, or it can be used in known coronary artery disease, as we, for example, discussed if cardiac CT determines that there's some disease but the significance is unclear, or if invasive coronary angiography shows some disease but the significance is unclear. So what cardiac MR then can offer is testing for the functional significance of such a coronary lesion. It can aid revascularization and guide for very complex coronary disease, for example, to perform targeted percutaneous coronary intervention. There is another reason why in coronary artery disease, known coronary artery disease, you may want to do some CMR stress testing, and in this case we're talking about dobutamine CMR. If late gadolinium enhancement shows a 25 to 50% or sort of just around the 50% transmural extent, then these segments can recover with an intermediate probability. If you want to further specify how likely they are going to recover following a revascularization procedure, for example, a coronary artery bypass graft or a PCI, then there is some suggestion that adding a low-dose dobutamine CMR protocol and assessing whether there's some functional reserve in these segments will guide the viability assessment and have some incremental diagnostic accuracy for viability over and above the late gadolinium alone. Now, what we're not going to talk about in this talk is other reasons why you might want to do CMR perfusion studies, for example, in hypertrophic cardiomyopathy, to look for perfusion defects which could be of prognostic relevance in hypertrophic cardiomyopathy. What we're also not talking about is the first pass perfusion for tissue characterization of cardiac masses, which actually doesn't require the administration of adenosine, for example. This is just a rest perfusion that can help just to look at the vascularization of a cardiac mass. What are contraindications to cardiac MR stress tests? In fact, all standard MRI contraindications, which include, as I'm sure you all know, permanent pacemakers, ICDs, any other non-MRI safe implants, metallic foreign bodies, claustrophobia, etc. As we would use gadolinium in perfusion tests, so this is not a contraindication if you plan to do dobutamine CMR, but for perfusion studies, if there are any contraindications to gadolinium, for example, previous reactions to gadolinium, or also if the eGFR, the glomerular filtration rate, is less than 60, you need to be cautious. It's not a contraindication. But if it's less than 30, you really need a very good clinical reason to perform and administer gadolinium, so that you can't get the information that you need, which may alter management of the patient, can't be acquired with any other investigation. So really this is a contraindication if the eGFR is less than 30 because of the risk of NSF, which we'll come back to in a second. Now for adenosine stress perfusion scans, if you've had caffeine intake within the last 12 hours, this can affect the response to adenosine because it counteracts the adenosine response. So the interpretation of your stress perfusion studies will become difficult. It's not really contraindicated, it makes interpretation far more difficult. Similarly, if patients have been on aminophylline or dipyridamole and haven't stopped that treatment. Severe asthma, an asthma attack can be caused by adenosine, is a contraindication. A high-grade AV block, uncontrolled heart failure, and essentially we've got a question mark here for large pleural effusion. So if a patient can't lie flat in a magnet, then you're probably can't do the MRI study, and also the patient probably then doesn't appreciate if they just about manage to hold their breath, that you give them adenosine if they're pretty unwell in the magnet already. Similarly, dobutamine, again, it's not a contraindication, but if patients are on a beta blockade, then dobutamine might not have the effects that you like, so you may want to stop the beta blockade 48 hours prior to the investigation. Alternatively, your approach might be, well, I want to see, is there any evidence of ischemia with the patient being on beta blockers? That might also be an appropriate question. History of ventricular arrhythmias, uncontrolled heart failure, and then again with these question marks. So basically, if patients are pretty unwell, then you might want to be a bit careful with the dobutamine in a magnet. Hypokalemia, clearly, because it can increase your risk of malignant arrhythmias. Risks of adenosine, very common side effects are sweating, chest discomfort, palpitations, and anxiety. Very uncommon are the more serious events, such as heart block, pulmonary edema, bronchospasm, VT, or ventricular fibrillation. Overall, these are extremely rare, at most 1 in 1,000. Dobutamine, serious side effects are a bit more common, maybe 1 in 500. More common are nausea, headaches, chills, urgency, anxiety, angina, and mild hypotension. More uncommon, the more severe side effects such as severe hypotension, pulmonary edema, or cardiac arrhythmias, including SVTs or VT or VF. Now, gadolinium contrast agents can cause nausea, headaches, taste alterations, and paresthesia. It's quite rare, reported to be about 0.4%. Anaphylactoid reactions are rare, and serious ones are maybe 1 in 100,000 really. Has got very low nephrotoxicity, which is a major advantage over the X-ray contrast agents. However, there is with the risk of nephrogenic systemic fibrosis in patients who've got severe kidney failure. It was first described in 1997, very rare, 200 cases worldwide. Only occurs in patients with renal impairment, mostly patients who are on dialysis or who've got an eGFR of less than 30. Quite poorly understood, but it mainly affects, it seems to sort of cause scarring, fibrosis in skin, and can basically affect all internal organs. I always think of it as similar to systemic sclerosis. It can cause contractures. There's no real treatment for it. Very rarely, well, if you do get it, in about 5%, it can lead to rapid progression and death. Some suggest maybe you should dialyze patients with poor eGFR who've received gadolinium, but there's no real evidence that that actually reduces your risk of NSF. It seems to be less common in more modern contrast agents with a cyclic structure, chelate structure. Dotrem, for example, has been used 10 million times, and there's no reported NSF case to my knowledge with Dotrem, for example. So that's really what I wanted to talk about briefly. I'm very happy to answer any questions. Thank you for your attention.